Hi, I'm Dr. Beth Pineles, and I'm a fellow in maternal fetal medicine, and I want to talk to you about maternal mortality and how we can solve it. U.S. maternal mortality is higher than any other nation in the world. You can see the countries listed here: New Zealand, Norway, Germany, Sweden, Switzerland, even the UK and Canada, which we think of as more similar to us, have less than half of the maternal mortality that we have, which is 17 maternal deaths per 100,000 live births. We also know that maternal mortality is increasing. We think that we have an amazing healthcare system, we can save anyone, but why is maternal mortality increasing to 20 pregnancy-related deaths per 100,000 live births in 2019? Most maternal deaths are actually preventable, which makes sense as to how other countries are able to keep their maternal mortality rates down, whereas we cannot. We typically blame the individual. We guide them to have a healthy lifestyle and diet, weight, physical activity, worry about substance abuse, as well as having preconception health care to address health problems and plan for potential problems and get early prenatal care. However, this guidance is very difficult without good access to healthcare. Our patients don't have a way to ensure that they are perfectly healthy before starting a pregnancy when they don't have healthcare access. So we need system-wide solutions targeting root causes. Here, we'd like to understand the key drivers of avoidable maternal deaths. And we've divided this into several key drivers. And first, we're going to talk about racial inequities. So racial inequities are quite extreme. So we remember that maternal deaths are 20 per 100,000 live births in total population, but we see that this is more than double in Black women, a little bit lower in white women and Hispanic women, but also elevated in Native American women. We also see disparities in women getting late or no prenatal care, which may be contributing to the disparities in maternal mortality. So you can see that Native Hawaiians and other Pacific Islanders actually have 20% of them have late or no prenatal care, 10% of Black women, all the way down to only 4% of white women. Then infant mortality goes along with maternal mortality in terms of racial inequities. And we see that from 3.6 per 1,000 live births in Asian women, we have actually over 1% of infants of Black ethnicity are dying in the first year of life. We would think that if you have an equal playing field, everybody has the same education, then this would wash out. You would not have a difference because it's all due to socioeconomic status. That's actually not true. We know that Black college graduates are 5.2 times more likely to die related to pregnancy than white college graduates. These are college graduates. Then if you compare Black college graduates with white people who do not even have a high school degree, they're still more likely to die related to pregnancy, 1.6 times more likely to die. So this requires equitable and universal coverage because a lot of these outcomes are related to structural racism, and we don't have that in our country. There's a lot of differential access to care based on race, ethnicity, socioeconomic status. But Medicare for All would also invest significant resources in underserved communities, provide training for healthcare professionals to combat racial bias, which is certainly an issue, and we've seen this in the media that healthcare professionals also need to learn about racial bias. And Medicare for All would also establish an Office of Health Equity to fund research and data collection on racial inequity, promoting primary care for underserved populations, all critical things for addressing racial inequities. In addition to racial inequities, Another huge problem driving maternal deaths is fragmented coverage. So the ACA mandated essential benefits for pregnancy, maternity, and newborn care. However, only some plans, a minority potentially, were included in this ACA requirement: individual marketplace plans and small group plans. Excluded from the ACA requirement are many types of plans. So even in people who have private healthcare insurance, many people do not have a plan that covers pregnancy, maternity, and newborn care. Chronic health conditions are super important right now. And we can see in an urban population that asthma has increased significantly from the 2005 to 2006 period to the 2013-2014 period. And then we see the same trend in high blood pressure, substance abuse, and diabetes. All of these are increasing at the beginning of pregnancy. And we see the same occurring in our rural population. So this is not just an urban population, but this is throughout the country. We're seeing increases in chronic health conditions. So here we're talking about prenatal care in the first trimester, which is one of those things that we said is difficult to have when you don't have health insurance prior to pregnancy. So in patients with private insurance, we see almost all of them are getting prenatal care in the first trimester. This is how it should be. With Medicaid, many of them, most of them are getting prenatal care in the first trimester. But if you take uninsured patients, only fewer than half are actually starting prenatal care in the first trimester. So they're not able to address those chronic conditions that we said are increasing. They're not able to prevent other conditions from occurring. We know that Medicaid expansion helps, so it does slow down maternal mortality. So this red line is the non-expansion states, and you can see maternal mortality sharply increasing from 2006 to 2016. And then in the expansion states, you see an increase, but it's significantly less than in the non-expansion states. But still, it's still getting worse. So Medicaid expansion is not the answer to solving the problem. But let's talk about what Medicaid expansion can do. Before the ACA, Medicaid already covered lower income pregnancies. And states that expanded Medicaid added more prenatal and postpartum coverage. So Medicaid expansion is actually saving lives, significant number of lives, 16 fewer deaths among Blacks, which is, again, you see more than the total number of deaths in multiple other industrialized countries. So Medicaid expansion, access to care does improve the situation and reduce maternal mortality, but it does not completely solve the problem because, first of all, not all states have Medicaid expansion. And second of all, not all people are eligible for Medicaid, even in a Medicaid expansion state. So here we can see uninsurance rates in non-expansion versus expansion states. So preconception, you have almost, over 1/3 of people have no health insurance preconception in non-expansion states. In expansion states, this is significantly less. And then postpartum, again, you have a significant portion of patients without insurance postpartum. And in expansion states, this is a lot less. And if you have preconception or postpartum, you have over half of patients having no insurance in one of those time periods in the non-expansion states. But even in the expansion states, you have 1 in 5 uninsured, either preconception or postpartum, which is really just unacceptable. These women are potentially having care for maybe 5 or 6 months in the middle of their pregnancy, and then are uninsured before and uninsured after. So Medicare for All will reduce pregnancy-related mortality, unifying the fragmented system. Medicare for All provides wraparound lifelong coverage for everybody in the US, including preconception. It's just all of the time. So you don't have to worry about when is the care being provided during pregnancy, preconception, postpartum. It's just throughout the whole lifespan. And Medicare for All would allow individuals to manage chronic conditions. So that they enter pregnancy in a much, much healthier state, and would also help prevent unintended pregnancies by providing contraception to patients prior to an unintended pregnancy. I see many, many patients who aren't on contraception because they just can't afford it. So what about a lack of providers? This is another issue that's a key driver of maternal deaths in this country that's quite unique to the United States. So we have a normal, typical number of OBGYN physicians in the United States, but very, very few midwives. So you can see here in the red is OBGYNs per 1,000 live births. So some countries have more than us, some countries have fewer than us, no big differences here. But if you add on the midwives, so these are people who are also taking care of pregnant patients, you see that many other countries have midwives making up the bulk of the prenatal care. And the only reason that Canada is a little bit less than us is they actually have family physicians, primary care physicians playing a larger role, and those are not shown on this graph. But in general, the US has a total number of prenatal care providers that is much smaller than other developed nations. So what else is happening? So in the United States, we're actually losing rural OB services because of financial incentives. Obstetrics is not a highly paid or high reimbursement for the hospitals, and there's a lot of liability involved. So a lot of rural areas are losing their OB services. So you can see that from 2004 to 2014, the number of hospitals providing OB services has really decreased in these rural areas. And 7 million American women live where there's no or limited access to maternity care. Here we're showing maternity care deserts. So there's 2 million women living in counties with no OB provider, no hospital, no birth center, nowhere to obtain prenatal care or even delivery care. So you can see huge swaths of the country where if you live there, you are going to have to travel dozens, sometimes hundreds of miles just to get maternity care. Then the burdens of scarce OB providers are really hard for also low-income urban parents. So we know that just going a few miles in a big city can be very difficult. I have patients who take several buses with several children just to get to a prenatal care appointment, which sometimes in a complicated pregnancy may be every week or 2 weeks. At the end of pregnancy, even for healthy women, is every week. So, this takes most of their day just to go to one, maybe 10-minute prenatal care appointment. We know that when an area loses OB services, this is very serious. Out of hospital births increase, preterm births increase, and then infant mortality doubles. So Medicare for all would improve the access to OB care, reducing pregnancy-related mortality, so that we would have providers attracted into underserved areas by creating the entire country would have good health insurance. So providers wouldn't have to only be in areas where people had health insurance. Providers could spend more time in direct patient care. And this is super important because we spend a lot of our time documenting and charting so that insurance companies will reimburse and patients won't get billed. And all of this paperwork is obviously not contributing to patient care. Midwives will become more available. Global budgets could protect vulnerable hospitals. And let's talk about lack of postpartum care. This is, somewhat part of the fragmented coverage, but this is really a critical piece right now because of when and where the maternal deaths are occurring. So most of our maternal deaths happen after the baby is born, which many people don't know. So in green are the ones that occur during pregnancy or the day of delivery, and in red are the ones that occur after delivery. And the only patient I cared for who died actually died 280 days after delivery. She presented late to care with COVID-19, was in the hospital for months and months after delivery, and ultimately passed away. So what do other countries do? Well, the World Health Organization recommends at least 4 postpartum visits. Here in the US, we typically have 1 office-based visit, and that is very standard. I would say most people think that 1 is completely adequate, and that's all we get. But also 40% of American births don't have any postpartum visits, because how hard is it to lug your newborn to the doctor, especially currently in the middle of a pandemic, just to check on yourself? Many women think, I'm going to worry about the baby. I'm going to go to my pediatric visits. I'm not going to worry about myself. I'm fine. But some people don't know if they're fine. They might not know if their blood pressure is high or their blood sugar is high. So most other countries provide universal postpartum home visits. In all of these countries, you can see that there are postpartum home visits multiple times in the postpartum period, which in the United States varies by state Medicaid program, individual insurer. I've really seen it very rarely, people having postpartum home visits. So Medicare for All would cover all postpartum care. There would be no insurance companies getting in the way of necessary care. I've experienced this as well. Insurance companies denying treatments, saying they're not necessary, and then me doing more paperwork just to get the patients the treatment that they need. And every other country really thinks that postpartum care is a worthwhile investment, especially as we saw that most deaths occur in that postpartum period. So there is a time when postpartum care may actually be improving patients' health and preventing maternal deaths. And Medicare for All is really the solution that would address all of these root causes. So the racial inequities, we would have universal coverage, so that would be equitable. If it's universal, it's equitable. We would be able to track disparate outcomes and promote care for the underserved. It would fix the fragmented coverage, because chronic conditions would just be covered over a lifetime, not just during pregnancy. It would fix the lack of providers by having global budgets, protecting universal hospitals, having universal coverage, drawing providers into underserved areas that currently there's no way to pay for a provider. If you can't get paid, you can't work. And the lack of postpartum care would also be solved because everyone would just have coverage all the time. No issues regarding race, ethnicity, income, geography. Everybody would just be covered. Motherhood really should not be deadly. Band-Aid approaches, we saw that the ACA is a step in the right direction, but really not solving the problem, because our maternal mortality rate is still increasing, even in expansion states. So we really need Medicare for all. Thank you.